Hi, my name is Anne-Sophie Lacharite-Roberge. I am a general cardiology fellow at Temple University Hospital. Welcome to CVI Heartbites. CVI Heartbites is a free, non-accredited educational program produced by the Cardiovascular Institute of Philadelphia, featuring succinct presentations delivered by experts on timely topics in cardiovascular medicine. This CVI Heartbites segment focuses on cardiovascular disease in the age of COVID-19 and is titled COVID-19 and Pregnancy, the Fear of the Unknown. Please note, this presentation was recorded on April 23rd, and the information was up to date as of that time. At the end of my presentation, you will see some additional resources and have the opportunity to contact me with any questions you may have. The COVID-19 pandemic has brought widespread fear to all populations across the globe, specifically to our patients who are immunocompromised, elderly, and who suffer from chronic disease, placing them at higher risk for developing critical illness. It has been challenging to manage this disease as the information changes constantly, and we are presented with new data daily. For many populations at risk, the risks of getting exposed to COVID-19 have been made clear and are now well described. In fact, the medical community is now focused on gathering data to improve management of these patients. However, one particular patient population remains at risk and without clear answers: pregnant women. Truthfully, we may not obtain the desired answers until these women infected with COVID-19 give birth several months from now. This can be incredibly anxiety-provoking for new mothers who worry not only for their health, but also for the health of their infants. In this short segment, we will review the most current data on maternal, fetal, and neonatal outcomes in the COVID-19 pandemic. Looking at previous data from several case reports and small case series on other coronaviruses structurally similar to COVID-19, more specifically SARS-CoV and Middle Eastern Respiratory Viral Syndrome, MERS-CoV, pregnant women were at high risk for poor obstetrical outcomes, including severe maternal illness, maternal death, and spontaneous abortion. In Hong Kong, in a small case series of 7 women, the clinical outcomes among pregnant women with SARS were worse than those in infected women who were not pregnant. More specifically, 50% of women who presented during first trimester sustained spontaneous miscarriages, likely from hypoxia caused by ARDS, and 80% had preterm deliveries. For patients with MERS-CoV, again, the data pool is incredibly small. Only 11 pregnancy-associated cases have been documented, but 91% of those patients had adverse clinical outcomes, including maternal death, perinatal death, and stillbirths. For both SARS-CoV and MERS-CoV, there was no evidence of vertical transmission, as opposed to other viruses such as Zika and Ebola, which are well known to have vertical transmission to the fetus. As we are all working on reviewing and critically appraising the data coming out of China, the New England Journal of Medicine published just on April 17th a correspondence titled "Clinical Characteristics of Pregnant Women with COVID-19 in Wuhan, China." In the letter, the authors emphasize the fact that we have limited data about the clinical characteristics and outcomes of pregnant women with the disease. From December 8th to March 20th, 2020, 118 pregnant women with COVID-19 were identified in Wuhan. 71% had positive PCR testing, and the remaining 29% had suggestive findings of COVID-19 on CT of the chest. The pregnant patients represented only 0.24% of all reported patients with COVID-19 during that time. 92% of the pregnant patients had mild disease, and only 8% had severe disease, which was broadly defined as hypoxemia. As of March 20th, 109 out of 116 women were discharged, and there were no deaths. 68 deliveries were performed over that period of time. However, a total of 14 out of 68 deliveries, which is 21%, were premature and 8 were induced. 7 of those because of concern about the complications related to COVID-19. To give you perspective, the percentage of preterm births in the USA is about 10%, and is actually reported to be similar in urban China, like in Wuhan, even slightly lower. Of the women who delivered, 93% underwent a C-section, and 61% of these procedures were performed because of the concern of the effects of COVID-19. Testing for COVID-19 was performed on neonatal throat swabs of 8 newborns, and no positive results were reported. According to their results, the risk of severe disease compared favorably with the risk reported in the general population. However, there were no conclusions drawn regarding the high rate of preterm birth or potential risks to the fetus prior to delivery. Coming back closer to home, the American Journal of Obstetrics and Gynecology published on April 9th data from the New York metropolitan area since the first reported case in New York State on March 1st. This case series included 43 test-confirmed cases of COVID-19. The disease course was mild in 37, 86%, severe in 4, 9.3%, and critical in 2, 4.7%. In this case, they defined mild disease as no or mild symptoms such as fever, fatigue, or cough, severe as tachypnea, hypoxia, or more than 50% lung involvement on imaging within 24 to 48 hours, and critical as respiratory failure, shock, or multi-organ dysfunction. Interestingly, and this has been reported in cases in China as well, 10 patients who were asymptomatic at the time of admission for delivery and were found to be positive for COVID-19 on universal screening went on to develop symptoms during their delivery or immediately postpartum. This is thought to be secondary to increased circulating blood volume in this period. In fact, several other respiratory diseases are exacerbated postpartum due to this phenomenon, including influenza. Again, in this small case series, early data shows approximately the same rate of severe disease as the rest of the population. We will now shift gear towards pregnancy complications, which is what continues to remain unclear and continues to cause significant anxiety and fear among the pregnant women population. Although the risk of contracting COVID-19 appears to be similar in the pregnant versus non-pregnant population, there is now evidence that may be pointing towards an increased risk of preterm births and C-sections. Hyperthermia is common in COVID-19, and it is well known that increased maternal temperature during first trimester and during organogenesis can lead to congenital anomalies, especially neural tube defects or even miscarriage. Early data suggests that pregnant women infected with COVID-19 could have an increased frequency of preterm labor, preterm birth, pre-labor rupture of membranes, preeclampsia, and C-sections for abnormal fetal heart rate tracings. A systematic review published on March 25th by the American Journal of Obstetrics and Gynecology, which included 41 COVID-19 pregnant patients, presented some non-reassuring, almost terrifying data. They reported a 41% rate of preterm births at less than 37 weeks, preterm pre-labor rupture of membranes in 19% of patients, and preeclampsia in 14% of patients. 91% of patients underwent a C-section, and in regards to baby's health, there was a 2.4% rate of stillbirth and a 10% admission rate to the neonatal ICU. Neonatal death was reported in 2.4% of newborns. It is important to note, however, that a vast majority of women in this study were mechanically ventilated in the ICU, and the perinatal deaths were not directly due to fetal or neonatal infection with COVID-19, as we now know with some confidence that there's no vertical transmission of the virus to the fetus. Indeed, of the 41 newborns assessed, there were no clinical sign of vertical transmission. One obvious limitation of these observations is the fear of the unknown for the provider, meaning that there's likely a rush to C-section in the hope that delivery will improve the management and care of the critically ill mother. Now, to bring us back home to our own specialty, obviously the data is even more limited, but there is one very small case series out of Newark Beth Israel Medical Center published on April 3rd, looking at 2 cases of COVID-19 and pregnancy who also developed a cardiomyopathy. In the population at their institution, 2 out of the first 7 cases of COVID-19 in pregnant patients actually developed a cardiomyopathy, both with a reported EF of 40 to 45% with global hypokinesis. Of note, both patients had high-risk features for developing a cardiomyopathy regardless of COVID-19. Therefore, we cannot draw conclusions regarding COVID-19 associated cardiomyopathy being exacerbated in the pregnant population. It does, however, raise interesting questions for the future. So a few details about this case series. Patient number 1 was 45 years old, her BMI was 45, and her initial workup revealed preeclampsia. BNP was 114, and her troponin was very mildly positive at 0.046. She was thought to be in clinical heart failure at the time of admission and was initially managed with IV furosemide. She underwent C-section because of the concern of the risk of COVID-19 associated pregnancy complications, and then unfortunately significantly decompensated from a respiratory standpoint, leading to a PEA arrest and eventual return of spontaneous circulation. As of April 3rd, she remained intubated in the ICU in critical condition. She never required mechanical circulatory support or anatropes for her diagnosis of cardiomyopathy. Patient number 2 is a 26-year-old with a BMI of 37, BNP less than 10, and a negative troponin. She also underwent C-section as a precaution because of the unknown effects of COVID-19 on pregnancy. She was not in clinical heart failure, remained stable post C-section, and was eventually discharged with close follow-up with cardiology. As mentioned earlier, both patients had significantly elevated BMIs, and one patient had confirmed preeclampsia, both risk factors for developing cardiovascular complications related to pregnancy. And only one patient was actually thought to be in clinical heart failure. It is very possible that these women could have developed a cardiomyopathy regardless of their COVID-19 status. And additionally, patient number 1 could have developed a stress-induced cardiomyopathy regardless of her pregnancy, given her critical respiratory illness secondary to COVID-19. So a few summary points. When looking up the CDC's recommendations for COVID-19 and pregnancy, the first page states the following: we do not currently know if pregnant people are at a greater chance of getting sick from COVID-19 than the general public, nor whether they are more likely to have a serious illness as a result. It is very challenging and will remain challenging to draw conclusions and make statements from these preliminary small case series. It seems like the risk of acquiring the disease as a pregnant woman is similar to the general population. However, what is quite concerning is that pregnant women who do become infected appear to have a much higher risk of pregnancy complications. And this is why the American College of Obstetricians and Gynecologists states that pregnant women should be considered an at-risk population for COVID-19. So for now, and until we have more data available, especially in regards to these complications, it is most likely safest for pregnant women to exercise more caution than the general population, as it is suggested by the American College of Obstetricians and Gynecologists. So here are some additional resources on COVID-19 and pregnancy. If you have any questions for me, please email CVI's executive director at cvi.markhartnett@verizon.net, and questions will be sent directly to me. Feel free to share this link with anyone who might be interested in the information. And please let us know if there are other topics of interest to you. Thank you for watching the CVI Heartbites segments. For more information on other CVI Heartbites segments, as well as other CVI educational programs, please visit us at cviphiladelphia.org, or you can also follow us on Twitter at CVI_Phila, #CVI Heartbites.